Alright, guys, here's chapter 32 spine motion or spinal injury and spine motion restriction. Alright, we're going to go over chapter objectives, education standards, key terms, A&P of a spinal injury, emergency care for suspected spinal injury, guidelines for spine motion restriction, techniques and special considerations. Alright, so your case study. EMT Sarah and Angela arrive on the scene of a person who made a hard landing while skydiving. Sarah approaches the patient, instructing her not to move, and immediately provides inline stabilization of the head and neck. The patient is a 25-year-old female, landed on both feet, and is complaining of pain in both ankles and her lower back. How could this mechanism of injury lead to injury of the spine? And what kind of signs and symptoms are we going to look for when we are assessing this patient? All right. We're going to learn special considerations of assessment and emergency care for a patient suffering from possible spinal injuries. All right. This can be collisions, falls, recreational activities. This includes injuries to the spinal column and the nervous system. And these patients must be handled in a way not to provide even more damage than what they've already incurred, okay? So let's quickly review the nervous system. You have two parts, all right? You have the autonomic. It has two main functions, communication and control. It enables awareness and reaction of the environment, and it coordinates body responses to changes in the environment. You have the central and the peripheral. The central is going to be your brain and brain and cranial nerves, and the peripheral nervous system is going to be your spinal cord and your spinal nerves. Okay. You have voluntary functions. The autonomic system is partly independent of the rest of the nervous system. The sympathetic nervous system and parasympathetic nervous system are included in this autonomic nervous system. All right, your cervical spine is the first 7 vertebrae that form the neck. It's the most mobile and delicate of all the spine, and injuries to the cervical spine are the most common cause of spinal cord injury. Next, you have the thoracic spine. It's 12 vertebrae directly below the cervical that compose the upper back. Lumbar spine is the next 5 that form the lower back. The sacral spine, or your sacrum, is the next 5 vertebrae, and these are fused together and form the rigid posterior portion of the pelvis. Then you have the coccyx, or the tailbone, and these are the 4 fused vertebrae that form the lower end of the spine. All right. This diagram should be in your book. The spinal column, vertebral column, is the principal support system of the body. Ribs originate from it to form the thoracic cavity, and the rest of the skeleton is directly or indirectly attached to the spine. Because light touch and pain are carried by different tracts, the patient might not feel light touch, but can feel the pain of a pinch. All right, this finding can be present if the spinal cord is partially severed. A patient may have spinal cord injury without spinal column injury. Okay, you can have compression. This is the weight of the body is driven against the head. It's most common in falls, diving accidents, MVCs, and other accidents which a person impacts an object head first. Flexation. There is severe forward movement of the head in which the chin meets the chest of the torso is extremely curled forward. Flexation. This is a severe backward movement of the head in which the neck is stretched or the torso is severely arched forward. Rotation. You have lateral movement of the head or spine beyond its normal. Lateral bending is when the body or the neck is bent severely from the side. distraction, the vertebrae or the spinal column are stretched and pulled apart. This is what you're going to commonly see with hangings and stuff. Then you have penetration. There is injury from a gunshot wound, stabbing, or other types of penetrating injury. Alright, so you must suspect spinal injury in any case that might involve one or more of these mechanisms, even if the patient appears to move normally. Injured vertebrae that are still aligned but unstable can become unstable at any point, and damage or severe spinal cord injury can occur. You can even sever the spinal cord, okay? Although a patient complaining of pain to the spinal column likely has a vertebral or spinal column fracture injury, they could have a vertebral injury without a spinal cord injury. A loss of motor or sensory function indicates a spinal cord injury. However, it does not imply that there is an actual vertebral fracture. Okay? A patient in spinal shock can present with complete paralysis that might resolve within 24 hours to several days after the injury. And a lot of times they'll use steroids with these to decrease the swelling and stuff. Alright, a male patient might have an involuntary erection of the penis called a priapism. This is most commonly found in spinal injuries and shock. Treatment for spinal shock is much the same as for any other shock. Spine motion restriction must be applied and the patient must be kept warm because of the increased heat loss from peripheral vasodilation. Alright, spinal cord injury versus spinal column. This is when an incomplete spinal cord injury does not involve all three tracts. Some but not all vital signs are present. Some but not all signs of spinal injury are present, and the pattern of loss function is reflected in different syndromes. Alright, we're going to talk about this. There's illustration in your book. You have central cord syndrome, anterior cord syndrome, and Brown-Séquard syndrome. Alright, central cord syndrome results from injury to the central part of the cord. Anterior cord syndrome results from injury to the anterior part of the cord. And Brown-Séquard results from injury to the right or the left half of the cord. Alright. In central cord syndrome, the patient presents with a loss of motor function or weakness and loss of pain sensation to the upper extremities, while motor and sensory functions remain normal in their lower extremities. In anterior cord syndrome, the patient loses the ability to feel pain and crude touch below the site of injury, and most likely experiences the loss of motor function below the injury site. However, the patient retains the ability to feel light touch above and below the site of injury. In Brown-Séquard, the patient loses motor function and light touch sensation on one side of the body while retaining pain and sensation on that same side. On the opposite side of the body, the patient retains motor function and light touch while losing the sensation of pain. Okay? What's our emergency care going to consist of? Alright? We're going to do a scene size up. We're going to look at crashes, falls, blunt or penetrating trauma, sports or recreational injuries, gunshot injuries, and electrical injuries, hanging, diving accidents, unresponsive trauma patients. Alright? So, you might arrive at a collision scene and find a patient walking around or sitting in the back of a police car. This does not rule out any kind of possibility of spinal injury, especially an incomplete spinal cord injury or vertebral injury. Often, a patient with a stable spinal injury does not exhibit signs and symptoms consistent with injury to the spine. However, improper management by either the patient or you can potentially cause a stable injury to become unstable, resulting in permanent neurological damage or even death. Okay? You want to look at your mechanism of injury. Okay? This evidence should create a high index of suspicion that the patient was propelled forward in the crash and struck their head on the windshield or the steering wheel. This would likely have caused the head and neck to bend or flex forward during forward movement and bend backward or hyperextend during the rearward movement. Both motions are significant mechanisms of injury that might not be suspected if the damage to the vehicle were not observed. An injury to the cervical spine in the third or C3 to the fifth C5 cervical vertebrae might injure the phrenic nerve that controls the function of the diaphragm. All right, because the diaphragm provides more than 60% of the effort to breathe, the patient can develop respiratory failure and require ventilation. You're going to have to manually bag these patients. They're not going to be able to breathe on their own. All right, spinal cord damage from a cervical spine injury can block nerve impulses traveling from the brain to the diaphragm and intercostal muscles, which are necessary for your adequate respirations. The mental status of a patient with a spinal injury can range from completely alert to unresponsive or anywhere in between. Based on your assessment findings, categorize the patient as either high or low priority for emergency care and transport. If the patient is unresponsive, responsive but can obey your commands, or displays an abnormal respiratory pattern, or obvious signs of injury such as numbness and paralysis, this is considered a high priority for emergency care and prompt transport to the highest level trauma center based on your destination protocols. All right, some protocols allow you to instruct the patient to perform self-restriction, which is to ask the patient to restrict or prevent his movements to keep his head and neck and spine in proper alignment. All right. You want to assess their flexation. Bend your arm at the elbow and place them across your chest. This flexation tests motor function at the C6 level. Straighten your arm and then bring them to either side of your body. This tests motor function at C7. Spread your fingers out on both sides and don't let me squeeze them together. This is at T1 or thoracic 1. All right. This is T2. Assess finger adduction. Can they close their fingers? All right. Hold both arms out and don't let me push your hand down. This is function at C7. Place your hands on the top of the patient's feet. Pull up against with your feet. Your PMS assessment that you do. This tests the function of level at L5. All right. Push against my hand with your feet. Dorsiflexation, test the motor at S1 and S2. A cotton swab with a wooden stick can be used for checking both pain and light touch. Pretty sure I've never seen a cotton swab with a wooden stick on an ambulance before, but if you got one, use it. Have the patient close their eyes. With the sharp end of the swab's wooden stick, poke one of his hands. When the patient grimaces, moans, or responds in some other way, ask, where does it hurt? Repeat the test on the other hand and on each foot. All right, so here's your foot test. All right, just like with PMS, can you feel me touching you? Which toe am I touching? Assess their response to touch. Evidence of deformity, tenderness, contusions, lacerations, punctures, or swelling to the spine or around the spine should greatly heighten your suspicion that a spinal cord injury exists. All right, hypovolemia and spinal cord injury can both be present in the same patient. Therefore, be cautious in your assessment because spinal cord injury might prevent the typical signs of hypovolemic shock from occurring. All right, so what kind of questions can you ask? Does your neck or back hurt? Where does it hurt? Can you move your hands and your feet? Do you have any pain or muscle spasms along your back or the back of your neck? Do you have any numbness or tingling sensations? What were you doing when the pain started? What was the onset associated with fall or other injury? Did you move or did someone move you before we got here? Were you up walking around? Spine motion restriction should be based on physical assessment findings, not solely on the mechanism of injury. It is imperative to recognize that a patient's lack of pain in the spinal column or his ability to walk move his extremities, and sensation does not rule out the possibility of spinal column or incomplete spinal cord injury. After a thorough assessment of a patient with blunt and penetrating trauma, these indicators show that the patient should be transported using spine motion restriction. You have a GCS less than 15, suspected TBI, altered mental status, pain or tenderness of the spinal column, paralysis, weakness, numbness, tingling. If any of these indications are found during your assessment, you must provide spine motion restriction throughout the remainder of the assessment, treatment, and transport of the patient. All right, complications of spinal injury. They can have inadequate breathing, paralysis of the respiratory muscles, respiratory failure. Respirations can be shallow with little movement of the chest or abdomen, and you're gonna need to ventilate these patients with positive pressure. Incomplete spinal cord injury can cause loss of motor and sensory functions in different areas of the body. All right, you have paralysis, you have paraplegia, quadriplegia, hemiplegia is more common in head injuries and strokes. This is when you have paralysis on one side of the body or the other. All right, and you want to always look for other reasons of hypotension, inadequate circulation, poor tissue perfusion. Your signs of shock. Okay, if the patient complains of severe pain to the neck or cervical spine, or the head does not easily move, maintain the head in the position found. Ensure that the head is in a neutral and inline position. Insert an OPA or NPA if necessary. All right. In these patients, we want to use the jaw thrust maneuver. We do not want to manipulate that neck at all with the head tilt, chin lift. All right. We're going to need to have our suction ready because we need to suction the secretions without turning the patient's head. An improperly sized C-collar can cause more harm to the patient, compromise airway, and further aggravate a potential spinal injury. All right, we've pretty much already gone over how to size and apply a C-collar. It is safer to err on the side of caution and provide spine motion restriction if spinal injury is suspected. Spinal motion restriction devices can always be removed at the emergency department after the physician or radio x-rays determine that no spinal injury exists. Because spinal injury is rarely an isolated injury, look for signs of hypovolemic shock. The skin becomes pale, cool, and moist. The blood pressure falls, heart rate increases. The patient's mental status decreases. Remember that a decreasing level of responsiveness is an early sign of a head injury. All right, back to our case study. The patient is alert and oriented with a patent airway and adequate breathing. She has strong radial pulse at 88 per minute. She has movement and sensation to pain and light touch in her upper extremities. She has sensation to pain and light touch in her lower extremities. But she has bilateral ankle injuries, which makes assessment of motor function difficult. So, what kind of equipment will Sarah and Angela need to provide spine motion restriction for this patient? Well, they're going to need a C-collar, a backboard, straps, padding for the voids, headbed, C-collar, okay? And describe the procedure Sarah and Angela should use to provide spine motion restriction for the patient. This is going to be just like we do in class, all right? BSI, scene safe. Hey, ma'am, hey, how you doing? You okay? Do you hurt anywhere? Inline stabilization, turn that over to your professional partner, PMS, all that good stuff, all right? It is estimated that up to 5 million patients a year with no evidence of spinal injury receive spinal immobilization. The backboard also became a popular and convenient device to move patients regardless of suspected spinal injury. It is impossible to achieve complete spinal immobilization. The ACEP recommend spine motion restriction over immobilization attempts. Spine motion restrictions aims to maintain anatomical alignment of the spine and to keep gross movement to a minimum. The specific adjuncts are not mandatory. Okay. The indication for which patients should receive spine motion restriction are based on various sources. You need to follow your local protocol, which might include many described in this section. All right. Other spine motion restriction criteria might be required by your local protocols. Some can include motor vehicle crashes with high energy, rollover ejection, and pedestrian vehicle collisions. Patients with penetrating injuries to the head, neck, torso do not have any neurological deficits or indication of spinal injury should not receive spine motion restriction utilizing a backboard. All right. You can do spine motion restriction by application of a soft cervical collar, a rigid cervical collar, and the patient secured to a vacuum mattress, cervical collar and the patient lifted and moved to the stretcher using a scoop stretcher, cervical collar and the patient lifted and moved to the stretcher using a backboard, cervical collar and a vest type device applied to the patient. This is going to be your KED. Alright, so we have cervical collars, can increase intracranial pressure, cause pressure sores. Alright, use your fingers to measure the distance from the shoulder to the chin, the distance between sizing posts. These are the little black fasteners on the lower edge. Measure. Alright, assemble the collar. Keep in mind that the current spine motion protocols, the real purpose of the cervical collar is simply to remind the patient not to move their head and neck. Alright, so apply your cervical collar. Because of the many hazards listed for rigid cervical collars, the soft cervical collar is a viable alternative. You're not going to see many ambulance services carrying these. Alright. The correct application of the cervical collar can create an unnatural separation of the spine by as much as 11.3 millimeters. This is enough to cause a secondary spinal injury. All right, if not fitted properly, placement of the cervical collar might lead to greater movement of the head and neck. Alright, the cervical collar can cause separation of C1 and C2 while stretching the spinal cord. The cervical collar itself can produce pain and discomfort. Alright, so putting them on a long backboard. We have long rigid backboards, and then the alternative devices such as your vacuum mattress and your scoop stretcher. Alright. KED is most common short board that's used, although they're rarely used for MVCs. We use them for pediatric patients, pelvic fractures, stuff like that. But current research has shown that more manipulation can occur when applying and using these devices as compared to having a patient simply extricate themselves from the vehicle while maintaining their own self-restriction of their head and neck. EMS crew can instead remove the patient using rapid extrication. Alright. The ambulatory patient. Instruct the patient to hold their head in a neutral inline position and do not move it. When approaching the patient, do so from directly in front of them so that they can remain focused forward and don't move their head and neck to the side to look at you. Immediately instruct your patient as you approach to bring their head and neck in an inline position by lining up their nose with their belly button and not to bend, rotate, extend, or flex their neck. They should bring their feet and toes together in line with their umbilicus and nose. You want to assess the patient for any kind of pain. Ask them if they have pain anywhere else, especially in their neck or along their vertebral column. Palpate the posterior vertebral column gently. Alright, determine if they have any abnormalities to the bones in there. Assess their PMS. Alright. Instruct the patient to remain in a supine position and constantly maintain self-restriction until instructed otherwise by the medical facility. When you encounter a supine or prone patient with a suspected spinal injury, first ensure that all life-threatening situations have been managed. Alright, Log rolling a patient, we all know how to do this. This is best done with several people on each side. All right. We want to make sure that we don't move one side of their body and not the other. We want to make it a swift, quick, all-in-one move, and we always go on the headman's count. All right. The patient might be able to self-restrict if they are alert and can obey commands. Secure the patient to the stretcher mattress. All right. Instruct the patient to maintain self-restriction and rotate 180 degrees until their back faces the stretcher. Have the second EMT, who should now be positioned on the opposite side of the stretcher as the patient prevents the stretcher from moving and guides the patient back onto the mattress. All right. Assess pulse motor sensory before and after applying your devices. All right. Here's your KED. We've already gone over this. Inline stabilization, PMS, put your C collar on. Position the short spine device behind the patient. Examine the back. Be careful that the EMT who is holding inline stabilization does not move the patient excessively. Slide the board behind the patient as far into the seat as you can. The top of the board should be level with the patient's head, and the bottom of the board should not extend past the coccyx. The body flap should fit snugly under the patient's their armpits. All right. Secure the device to the patient's torso. Make sure the straps are tight enough to prevent movement of the device laterally and vertically. All right. Then we're going to put the ischial straps on. All right. Make sure these are secure. Pad the patient's head. You can tie their hands together, or you can just tell them to hang on to one of them straps right there. Okay. Me personally, I don't want you to tie my hands together. All right. Position the long backboard under or next to the patient. Rotate them until their back is in line with the backboard. If it is not possible to get a long backboard next to the patient, lift the patient under their arms with the straps, not their arms themselves, but where the straps go. All right. Put them on the long backboard and then release the ischial straps, okay? Please release the ischial straps. All right. Rapid extrication. This is called rapid rollout. The scene is not safe. Patient's condition is so unstable that you need to move them to transport them immediately. The patient blocks your access to a second, more seriously injured patient. All right. Put a cervical collar on, spin them onto the backboard, get them out, okay? That way the fire department and other people on scene can get access to a more critical patient. All right, if time and resources and patient condition permits, removing the roof can enable better access to the patient and easier removal using the rapid extrication technique. All right, special considerations. Thorough assessment of a patient is difficult under any circumstance, and the presence of a helmet makes the task even more difficult. But the removal of a helmet should not be an automatic step, because removal could risk aggravating a spinal injury if one exists. All right. So, helmets, leave the helmet in place if it fits well and there's little to no movement. You do not see any impending airway problems. Removal could cause further injury. You can provide spine motion restriction with a helmet on. It does not interfere with your ability to reassess airway and breathing. Remove the helmet if, and only if, it interferes with your ability to assess or reassess airway and breathing, interferes with your ability to adequately maintain an airway or manage the airway, it does not fit properly, it interferes with spine motion restriction, or the patient is in cardiac arrest. Any patient you find with a helmet and you take the helmet off, you need to transport the helmet to the emergency room with you. This is something that the doctors will want to look at. Okay, you have two basic types. You have sports helmets and motorcycle helmets. You can cut the plastic clips off of a face mask. Alright, so, and here is how to remove a helmet if you have to. One rescuer stabilizes, puts a hand on each side to prevent the patient's mandible from moving. The other rescuer slides their hand inside the actual helmet to prevent more movement than what is needed. Alright, and then the first rescuer slips the helmet off. Okay, that's how that's done. Alright, recommendations now state, when appropriate, helmets and shoulder pads should be removed before transport of an athlete with a suspected cervical spinal injury. This rationale for equipment removal is due to advances in sports equipment technology, and removing this equipment expedites the athlete's care. Another reason they should be removed at the time of transport, the coaches and stuff will have more experience with equipment removal than other medical teams or members in the emergency department. When all equipment has been removed, a cervical collar should be applied. Alright. Car seats involving crashes might have lost the integrity and structure and might not provide protection for a child if another crash were to occur. Transfer the child to a backboard. Alright. In children less than 8 years of age, if any mechanism of injury suggests possible spinal injury, it is prudent to provide spine motion restriction appropriate for the young kid. Alright, you can put a C-collar on them, make sure it fits. If you don't have a collar that fits, stabilize the neck with a rolled towel. Okay. Alright, lay the car seat back, or put a backboard, kind of like you do with a KED, down the back of the car seat. Lay the seat back and then slide the kid onto the backboard. Okay. You want to be able to make sure you pad behind the shoulder area. Okay. Alright. This will allow for alignment of the head, neck, and spine. Do not strap across the abdomen. Alright. Pediatrics' torso and lower extremities need to be padded adequately to elevate them to the level of the head to achieve a neutral inline position of the neck. Alright, you can stabilize the neck with the towels. You can tape the towels to the backboard or hold it in place with the head stabilization device. Alright, Angela applies a cervical collar after assessing the neck as Sarah continues manual stabilization of the spine. Since the patient is stable, they quickly splint both ankles to prevent further pain and damage upon moving her. Sarah and Angela apply a long backboard for spine motion restriction and begin transport. At the hospital, the patient is found to have compression fractures of L3 and L4. She requires surgery for both the ankle fractures. Alright, so our summary. Spinal injuries can lead to permanent disability. Proper management to avoid movement of spine is imperative, and spinal cord injuries can be partial or complete. Spinal cord injuries can cause loss of motor and sensory function. That's why I tell y'all, check PMS anytime you move a patient, anytime you put a C-collar on, anytime the patient moves themselves, check your PMS, okay? You cannot check PMS too much, but you can check it too little, okay? And we need to know when they lost pulses, motor, and sensory, all right? So complications of spinal cord injury include respiratory failure and neurologic shock, all right? This concludes chapter 32. So here goes nothing.